And with that, I'm going to turn it over to Emily for the last portion of our talk on long-acting injectable buprenorphine.
Thanks, Elisa. Okay, so I'm going to talk to you guys today about long-acting injectable buprenorphine. This is one that hopefully after this talk you feel more comfortable using and potentially explore how to get it in your clinic if you don't have it already. So there's some pros and some cons when thinking about injectable buprenorphine instead of over the sublingual. I think there's a lot of pros. Unfortunately, the cons offer some very significant barriers to overcome. They're quite expensive. They're usually in the $1,000 to $2,000 range. There's complicating billing models, which can be confusing. There's a buy-and bill model that most clinics have to use. There's a pharmacy bill model, and kind of really figuring out how to navigate and properly set up both of those can be really challenging for ambulatory care spaces. And then the availability of administering provider, all of those challenges in setting up the billing of it and the cost of it, that are really barriers for clinics exploring it. And so especially in rural parts of our state, to try and find a clinic or a provider that will give the injection to the patient can be quite challenging. That being said, there are quite a few pros that also come along with injectable buprenorphine. One, it doesn't require daily dosing, so the patient doesn't have to keep track of taking it multiple times a day. It removes the concern if they have lost or stolen medication frequently. It does offer a more steady and continuous plasma concentration of buprenorphine instead of the up and down that you get with daily sublingual administration of buprenorphine. There's some argument that says it's a better overdose protection. I think I take this with a grain of salt because it does come from a drug company funded study, but they essentially looked at different serum levels and then gave those patients fentanyl and saw like what serum level correlated with the best protection against respiratory depression. They found that there is good respiratory protection at 2 nanograms per milliliter, which is why I referenced the serum levels in an earlier slide, but that it was best protected against at 5 nanograms per milliliter, which is only really found in one of the injectable formulations, which I'll highlight on a different slide. But there is some definite argument in saying that there is better overdose protection because you do get a more continuous serum plasma level and you'll have longer times above the 2 nanogram per milliliter serum level. And then there was a really great study that was done in 2019, so quite a while ago, but they look at patient-centered outcomes, and they found that the patients who were on injectable buprenorphine had improved health measures, that increased employment, increased medication satisfaction, and then decreased healthcare utilization as well. So there's a lot of good reasons to explore injectable buprenorphine for your patients. There's 2 different options. I generally do not like to use branded names of medications, but it's really challenging to do that in this situation because they're both long-acting injectable buprenorphine. There's no difference in the names to differentiate between the 2 of them. So I will unfortunately use the 2 different brand names just to make sure we're really clear, as they do have different pharmacokinetics and different dosing strategies. And so I just want to make sure that we all know what dosing strategy belongs to which formulation of the injectable buprenorphine. So right now on the market, we have Sublocade, which has been around the longest, and that has 2 different dosings. There's a 300 and a 100. And then newer on the market is Brixadi, that comes in 4 different monthly formulations as well as a weekly formulation. So those are 2 different long-acting injectable buprenorphines. We're going to go with Sublocade first. So some important pharmacokinetic parameters to point out is that it peaks in 24 hours. The half-life is really long. It will last anywhere from 43 to up to 60 days, especially at steady state. So you're going to get a long duration of action, a long tail of that medication. That long half-life also means it's going to take some time to get to steady state. So you won't approach steady state serum levels until at least the 4-month mark, if not the 6-month mark. It does have, each dose contains 833 milligrams of NMP. And I only bring this up is that NMP is a potential teratogen. And so the hesitancy to use in the pregnant population really revolves around this compound. Each Sublocade dose does have 833 in there. Brixadi has a little bit less. I don't think we know that if it's the quantity of the exposure or just exposure itself that's important, but it's just something to think about, is that there's potential less exposure to the NMP in the Sublocade, or in the Brixadi, I'm sorry. The dosing, it used to just be one dosing strategy. You would do 300 milligrams for 2 months, and then you would do 100 milligrams monthly after that, and that would be the maintenance monthly dosing. There has been some off-label use of a higher dose for quite some time now, so patients could require 300 milligrams monthly instead of dropping down to the 100 milligrams a month. This is now in the updated package insert, so that is an FDA-approved dosing strategy now. And then there's a newer one that's out. I'll highlight a little bit more detail later on, but it's a more rapid initiation of Sublocade where you would do the 300 milligrams 7 days apart. And then after that, you would go to 300 milligrams monthly. And so you're really just trying to achieve a higher serum levels for those patients in the first month. And then the package insert does recommend baseline and monthly LFTs for ongoing Sublocade. So let's talk about serum levels real quick. And I think that the serum levels are important to think about when troubleshooting therapy for patients. So this red box is the average serum level on different dosing. So you can see here a patient who's maintained on 24 milligrams of the sublingual buprenorphine will have an average serum level of 2.9. So then if we transition them over to Sublocade and we do their initial 300 milligram dose, their average serum level is a little bit less. Is that clinically significant? Probably not, but it could explain why patients would report continued withdrawal or cravings in that first month. And so that would be a reason why we might need to supplement with sublingual for the first month while we're waiting to get to steady state. Now, once I get to steady state, that average serum level is significant. It goes all the way up to 6.5, which is quite a bit. And so they should generally not need sublingual supplementation once reaching steady state. Oftentimes what that looks like for us and our patient population, we'll start them on sublingual, we'll do their first dose of the 300 milligrams of Sublocade, and then we'll change their sublingual dose to as needed. So we'll change it to 4 to 8 milligrams every 8 hours as needed for continued cravings and withdrawal, and kind of let the patient drive when and if they need more. There's other providers in our group that will wait until the 3-week mark, and they'll reevaluate them at 3 weeks and say, are you feeling cravings or withdrawal now? And then they start supplementing at the 3-week mark, because that's really when the serum level probably drops below 1.5 to 2. So many ways to do it, but do know that the supplemental sublingual buprenorphine could be necessary for some of our patients. Okay, how do you start Sublocade? There's a few different ways to do it. If they're already stabilized on sublingual regimen, that's really great. You can just give them that injection. It peaks in 24 hours, and so oftentimes we'll have our patient take that sublingual, their whatever dose of sublingual that they're on that morning, because you won't get significant serum levels for quite some time. And then again, if they are still having cravings or withdrawal, you can definitely add on some supplemental sublingual, either right away or at the 3-week mark, depending on your comfort level and then your patient experience as well. If they are new to buprenorphine, what I recommend doing is starting the patient on sublingual buprenorphine using whatever method you would normally do. So you use that shared decision-making method with your patient. You decide you want to do a high-dose injection on that patient. So you high-dose them on sublingual, and then after that, then you would transition them over to the Sublocade 300 milligram injection. If you're doing a low dose induction, I would at least get them to 8 milligrams of buprenorphine before you give any of the injectable buprenorphine. And that will really just protect against precipitating withdrawal, because we think with that low dose, when you get to that 8 milligrams of the dose stacking, you're less likely to precipitate. And so at least getting them to 8 milligrams of sublingual before giving the Sublocade injection will be important to think about. It used to be that the package insert said to wait for 7 days after sublingual stabilization. We have not done that in a long time in our hospital, and the package insert has essentially removed that, where you don't have to be stabilized on sublingual for 7 days anymore. Now, if the patient was on Brixadi, you could transition them right over to it. I would do the Sublocade probably a little bit earlier. We'll talk about it later, but Brixadi doesn't have quite the same tail that Sublocade does, and so they may need an earlier dose. So whenever they were due next, you could give the Sublocade on that day or up to 7 days before. Updates. So the package insert for Sublocade was updated a few months ago now. It allowed for additional injection sites. So it used to be that Sublocade could really only be given in the abdomen or the belly area. And now it's expanded so you can give it into the thigh, the buttocks, and the upper arm as well. You do get higher Cmax in the arm and the thigh, so the patient could be a little bit more sedated if it's injected in the arm or the thigh. But all of the other pharmacokinetic parameters are very similar. It's just you'll get a higher Cmax with those 2 injection sites. The Sublocade injection can be quite painful for patients. And so thinking about, I imagine an injection in the upper arm might be a little bit more painful for a patient than it would be in the abdomen. So if they're first starting, I'd recommend using the abdomen or the lower back. And then as they know what to expect with after each injection, then maybe you can consider transitioning into the upper arm. There's a few different ways to mitigate the pain that comes along with Sublocade injection. I think icing is a really good idea to do before, so throw an ice pack on there and wait a few minutes before you do the Sublocade injection. Some providers will use lidocaine before. It's off-label, it's not in the package insert, but certainly a practice that is done fairly commonly. But icing at least is a very good idea. The Sublocade used to be refrigerated, or used to require refrigeration. It has now been reformulated, and so it's allowed to be outside of the refrigerator for 12 weeks, which really frees up some of the storage barriers that can happen in clinic. It also now will suggest that maintenance dose of 300 milligrams is appropriate for patients instead of having to go down to the 100 milligrams. And that it also, interestingly enough, suggested that you could use 300 milligrams every 2 months as a substitute for patients who are on 100 milligrams monthly if they weren't able to get their monthly injection. So they're going to miss a month they're going to be on vacation, or their provider was going to be out and not be able to get their monthly 100 milligrams. You could sub every once in a while for the 200 milligrams and extend the frequency to 2 months instead of every month. Another thing that came out in this package insert was a very interesting rapid dosing protocol. The study's still pending, so it's not published yet, but there is information up on their website about doing a rapid Sublocade induction. And essentially what happens is they gave patients 4 milligrams of sublingual test dose. They waited an hour. If they didn't have bad reaction to it, then they would give them 300 milligrams in their tummy. They waited 7 days, and then they injected another 300 milligrams. They had a very low incidence of precipitated withdrawal, which is great. The tricky thing that is not readily available on the website, at least, hopefully it will be in the study when it's officially published, is that they had those patients wait 24 hours from their last illicit fentanyl use. And so this, when you look at it, this looks like it could be a viable option, especially for ED patients or ambulatory care space where they came in. You could very easily give them 4 milligrams sublingual in the office and then the 100 milligrams to transition them rapidly. But the key is to wait 24 hours from their last illicit fentanyl use. And that's what's going to still allow you to have those same low rates of precipitated withdrawal. Sublocade missed doses, because it does have that long tail on there. It's more forgiving for patients who aren't able to come every 28 days to the clinic. This is a really great Curbsiders. If you guys don't know about it, Curbsiders Addiction Medicine podcast is awesome. They have a lot of really good topics out there. This one was super interesting as well. This was with a doctor that practices in Vancouver, Canada. And this is their recommendation for how to manage missed or late doses, where if it's 4 to 6 weeks out, whether they're at steady state or not, you would give the next injection without any sublingual test dose. If they're 6 to 12 weeks out and they're at steady state, so they've gotten at least 4 injections, then you can do the next injection without any sublingual test dose. If they're 6 to 12 weeks out and they're not at steady state, so they have not received at least 4 injections, then you're going to need to give them a sublingual test dose. And anywhere from 12 to 8 weeks, if they have ongoing use, then you would also need to supply or provide them with a sublingual test dose before giving their injection. Okay, moving on to Brixadi. Brixadi is the other long-acting injectable buprenorphine formulation. It has 2 different formulations. So there's a weekly and then there's a monthly. They both have different pharmacokinetics and different ways to start a patient and maintain a patient on there. So for the weekly, it has a slightly lower peak. So it's going to peak in around 24 hours. This is important for the direct to inject method that we're talking about later on. The monthly formulation is a little bit faster. So you're going to start to get significant serum levels at around 6 hours and will peak all the way up until 10 hours. The half-life is shorter. So the weekly, it will only last 3-5 days. The monthly, also a little bit shorter, or actually significantly shorter than Sublocade. So the Sublocade half-life is around 40 to 60 days. So the Brixadi monthly half-life is around 20-22. So about half of the Sublocade half-life. This is not going to be as forgiving for late or missed doses. Steady state, again, is going to take around 4 weeks for the weekly and 4 months for the monthly. The monthly formulation uses NMP, same thing that Sublocade does, but it has less. So Sublocade had 800, where the Brixadi, depending on the dosing that you use, has around anywhere from 50 to 100. The weekly doesn't have any NMP. The weekly uses ethanol and phosphatidylcholine and glyceryl diolate in there. The amount of ethanol in there, so when you're thinking about using this for pregnant patients, is quite small. So it's 0.061 grams in each injection. A standard drink in the US here is around 14 grams. So if the patient were to use weekly Brixadi every week during their pregnancy, their total exposure would be around 2 grams of ethanol, which is less than a standard drink in the US. It is something to counsel our patients on for sure, but just know that there is significantly less ethanol in the weekly than it is than a standard drink in the US is. That's all. Comparing serum levels. So the serum levels aren't quite as robust as Sublocade is as well. So you can see even on the highest monthly Brixadi. So this table's a little bit busy, so we can spend some time oriented to it. So this first column is sublingual buprenorphine. So we have 8, 16, and 24 milligrams of sublingual. And then that sublingual dose correlates to around 16 milligrams of the weekly and 64 milligrams of the monthly. The 16 milligram sublingual is around 24 milligrams for the weekly dosing and 96 milligrams for the monthly dosing. And then 24 sublingual is correlated to 32 of the weekly and 128 of the monthly. So then if you go to the blue box, you can see that's the average serum level that each of those confer. So the monthly formulation of let's go to the highest dose. So the 128 of Brixadi, which is equal to 24 milligrams of the sublingual. You get the monthly average serum level of around 3.9. So that is less than the 100, with Sublocade, where if you do the 300 milligrams a month, that average serum level is 6. So you get about half of the serum level that you would of the Sublocade. I think that's it. So how do you start patients on Brixadi? If you look at the package insert, what they recommend doing is for patients who are not currently on sublingual buprenorphine, you'd want to use the weekly formulation. You would give them a 4 milligram sublingual test dose. If they don't precipitate, then you would use 16 milligrams sub-Q once. You would then bring them back and reassess them in anywhere from 24 to 72 hours. And if they still have cravings or withdrawal, then you would use another 8 milligrams of the sublingual or the sub-Q weekly injection. You would then bring them back 24 hours after that, and if they're still having cravings or withdrawal, then you would give another 8 milligrams of the sub-Q injection. That's a lot for patients and for clinics to try and figure out. Additionally, I don't know very many insurance companies that will cover 3 different doses of the sublingual 4 hours apart. So to me, this doesn't feel like a very realistic way to start patients on Brixadi. So what you should do is you should start your patient on sublingual buprenorphine using whatever method you would normally do. So again, the high dose, the low dose, or the standard dose. And then once you get them to at least 8 milligrams or whatever dose they're stable on, then you can transition them over to the monthly or the weekly injection. That feels more realistic to me than doing this very complicated every other day potential injection of buprenorphine. The Brixadi dosing is fairly straightforward. There's good tables out there that correlates fairly well with whatever sublingual dose the patient is maintained on. So if they're on 8 to 10 milligrams of sublingual buprenorphine, that would equal to around 16 of the weekly or 64 of the monthly. And then all the way up to 18 to 24 of the sublingual dose, that would correlate to 32 milligrams of the weekly or 128 of the monthly. You can see that it kind of caps at 24 milligrams. So patients who are maintained on higher than that may not do well on Brixadi. You may not get the significant enough serum levels to control their cravings or withdrawal. And so potentially thinking about using Sublocade in patients who need more than 24 milligrams of sublingual buprenorphine would be an important thing to consider for patients. There is a new way to start Brixadi that's out there now. As a disclaimer, we have not done this yet. We're trying desperately to get our ED to do it, but are being very mindful of making sure that it's done properly. So this is not something that we're doing quite yet, hopefully in the near future. The evidence for it is really in ED, the ED patient population, and then there's small ambulatory case series out there. And so the direct to inject Brixadi is where they have no sublingual lead-in, and you just inject them initially with a weekly formulation of it. That slow peak of the weekly formulation, remember the weekly doesn't peak till 24 hours, where the monthly peaks much faster in 6 to 10 hours. So making sure that we're very mindful about ensuring that it's a weekly formulation that we're using when we do the direct to inject Brixadi. Both of these studies that are out there that I have referenced also at the bottom of the slide, they have a really low incidence of precipitated withdrawal. I honestly didn't believe it at first, but they do really, this way really does confer a lower risk of precipitating patients. And they're even able to start this when the patient's COW scores were really low. So the ED study, they looked at COW scores of less than 4 compared to COW scores of 4 to 8. And they found that the patients with 4 to 8 had a very low incidence of precipitated withdrawal. The precipitated withdrawal that they saw was really when the COW score is less than 4. And so that could be a learning point and something to incorporate into your practice, is maybe don't do the direct to inject Brixadi when their COW score is less than 4. This is just a pictorial representation of the serum levels. So if you look at this yellow or this orange line, this is the sublingual. So you get a high peak and then a trough and then a peak and the trough. The green line is the monthly formulation of Brixadi, so it's a much smoother downtrend, but also a significant peak. So you can see the uptick in the green line is quite severe, where this blue line is the weekly formulation. And so this gradual onset and gradual accumulation in serum levels is what really makes the direct to inject Brixadi successful. So how do you do this? Few things to implement when thinking about in your clinic. So I would create a guidance document out there, or create a guidance document for you and anyone in your clinic to reference. I would have a COW score of greater than 4, just knowing that when it's less than 4, you have a higher incidence of precipitating your patient. And ideally, you would wait 6 to 12 hours after their last use. Certainly, you can have a risk versus benefit discussion. If your patient is in clinic, they used 4 hours ago, and you know they're not going to come back the next day, and you have an opportunity to get them onto buprenorphine, then you have a risk versus benefit discussion. We're saying we could do this. You could experience precipitated withdrawal, and if you experience precipitated withdrawal, this is how we'll manage it. I would not do direct to inject Brixadi if they've had methadone exposure in the previous 72 hours. It is important to prescribe, or if you're the inpatient side, to order withdrawal adjuncts, so those comfort medications that Elisa presented on earlier. Make sure that we're using the sublingual weekly formulation. That's really key. Do not do this with the monthly formulation. And then the dose is also a really good thing to ponder. So in the ED study, they used 24 milligrams, which is the medium, the mid dose of the weekly. There's 3 different doses. They use the middle range dose. In the ambulatory case series, they really allowed the provider to tailor that dose to what the patient what they think the patient needed. So when they had low reported use, they used 8 milligrams instead of 24. Where if they had a higher reported use, then they used the 24 milligram injection for their patient. It's important to counsel their patients not to use any other opiates for 6 hours after the injection. So really try to refrain from using any more fentanyl until 6 hours after the injection has been given. Really to rely on those comfort medications instead. After 24 hours, then supplemental sublingual buprenorphine is allowed. Patients with high use patterns, that 24 milligrams may not be enough for them. It may not confer a higher serum level to protect them against cravings or withdrawal symptoms. And so certainly supplementing with sublingual buprenorphine will be important. We really need to wait 24 hours after that injection to make sure we don't precipitate that patient. And then the sublingual dose that you offer your patients should essentially get them to the 24-hour or to the 32 milligram max dose. So for example, if your patient was injected with 24 milligrams, then they could get anywhere from 16 to 20 milligrams of sublingual supplemental buprenorphine. That might look like 4 milligrams every 6 hours as needed. And then in the ambulatory case series, it was actually quite interesting. They transitioned their patient to the monthly formulation 48 hours after their initial injection. So the patient presented back, they were feeling good, and then they used the monthly formulation of Brixadi, and so they didn't have to come back every week to get their injection. Most patients do not want to present to a clinic every week, and getting in to see your provider to do weekly injections can be quite challenging sometimes. And so the monthly formulation might be better in a lot of situations. Switching between products. So if your patient is maintained on 300 milligrams of Sublocade monthly, they come in, they say these injections are too painful. I don't like the nodules that the Sublocade leaves for me. I want to switch over to Brixadi. Really exploring what dose is equal to each other. And I think really all the data that we have to go on is serum levels. And so if we compare the serum levels of 300 milligrams of monthly Sublocade, it's the highest dose of the monthly Brixadi is 128 milligrams. But even then, you do get less of an average serum level. So counseling your patients, you won't maybe feel quite the same that you will feel on this 300 milligrams of Sublocade. But let's try this Brixadi, see if you like it better. If the less painful injection is worth it to you, then we'll continue on the Brixadi. If not, we can always go back to the Sublocade, but just knowing that they will have lower serum levels on the Brixadi. And then I think the tricky part is what to do if the patient is maintained on 100 milligrams a month. So if you compare the average serum levels, the 100 milligram maintenance dose really falls in between the 2 monthly Brixadi dosing. So at 96 milligrams, your average is 2.9. At 128, your average is a little bit higher at 3.9. And so this is where it's good to engage shared decision making with your patients and saying we could do the 96 milligrams. It might be a little bit lower or you might have you will have slightly lower serum levels than you will with your 100 milligram maintenance monthly. That might mean nothing. You could feel exactly the same. Or if you're still having a little bit of cravings or withdrawals on your 100 milligrams a month, maybe we go to the higher dose of Brixadi and do a 128 instead. So really engaging with them what feels more correct for them. Things to consider when choosing between Sublocade and Brixadi. So Brixadi's half-life is shorter. It's going to be less forgiving of late doses, and it may not last that full 7 or 28 days. You may need to give it a week or two earlier because of the duration of action is just not quite the same, especially until they reach steady state. And so it's maybe for the first 4 doses, you give it at 3-week intervals instead. Where Sublocade has that longer half-life, it is much more forgiving for late or missed doses. With Brixadi, you have more dosing options, so you can really tailor that dose to that patient's-specific need. Where with Sublocade, you're kind of stuck. You get 2, you get 100, and you get 300, and that's really it. There is less, the Brixadi injection is less painful. We've heard from our patients that just don't require lidocaine before. So that could be a benefit for the patient. It also has a lower nodule. So the Sublocade can leave these little bumps under the patient's skin, and that can be bothersome to patients where you don't get that with Brixadi. The Brixadi administration is technically much easier to do as well. There's good training videos out there, but it comes in a pre-filled syringe and the volume is quite a bit less. Most Brixadi doses are all less than 0.5 milligrams. 0.5 mils, sorry, for injection, where the Sublocade is 1.5 mils. You do get lower serum levels with Brixadi, so that's something to consider for your patients. There's less NMP with Brixadi. Is that clinically significant? Not sure, but it is there. And then one note is that Brixadi does contain soybeans, so if your patient does have a soybean allergy, make sure you choose Sublocade for them. And then using the injectable to taper off sublingual is another question that we get quite frequently. So a lot of patients, when they're tapering off buprenorphine, the sublingual buprenorphine, can find it challenging because of that up down of serum levels. And utilizing an injection with that long taper off could be beneficial for your patients. And so there are some good case series out there that describe using just a single dose of 100 milligrams to aid in a smoother taper. If you try that for your patient and they still are having cravings or withdrawals after that single dose of 100 milligrams of Sublocade, you can repeat it at extended intervals. So instead of doing it every 4 weeks, maybe you come back and you do it at a 6-week mark. And then the second injection, you do it at an 8-week mark. And so extending out the time between injections could be another thing to consider as well. Or you don't taper the sublingual at all. The patient says, I want to get off buprenorphine. You have a risk versus benefit discussion with them and decide that that really is the right thing for the patient. Then you can utilize the Sublocade to get them off at the more standard dosing, where you would do the 300 times 2 and then 100 milligrams for 5 or 6 doses. And then you have significant amount serum levels, and that will gradually taper over months. So the patient doesn't, it's just much smoother titration off for patients. There isn't data out there yet to use Brixadi to taper patients off. The data currently just really lies with Sublocade. Obtaining Brixadi or Sublocade in the clinic can be challenging to figure out. So there's a few steps to consider and think about before. If you guys don't know about the Grayken Center is out of Boston. They have a lot of good resources for all things MOUD and SUD. They have really good stimulant use disorder resources, but they also have a very good injectable buprenorphine guide, and it even has example inventory logs and example policies to use. And so certainly check out their website and their guidance that they've put out there if you're looking at obtaining these in your clinic. But the first step to think about is that you have to apply for a DEA license. It was thought at some point that each individual provider would have to apply for the DEA license. And I think it's a 224 form, if I remember correctly. We now know that it doesn't have to be provider, but it can be clinic specific. So each clinic could just fill out the 224 form instead of each provider. The next step would be to enroll in REMS. So both of these medications are REMS certified, and the REMS essentially just says that you will not give it to the patient. It's fairly simple. It just says that you will not hand the Brixadi or the Sublocade to the patient, that some provider will administer it to the patient. Each Brixadi and so Brixadi and Sublocade each have their own REMS. And so if you're going to offer both of them in your clinic, you'll have to do 2 different REMS certification for your clinic. And then the next step to think about is to develop a storage system. These are controlled substances. And so legally it has to be double locked. And so like a locked box within a locked cabinet counts. A locked box within a refrigerator within a locked room counts, but somehow it has to have a double locking system. And then developing a system for records and inventory is important to think about. You have to track medication received, medication administered, and then regular inventory verification. This, again, where Graken Center's guide really comes in handy, and we'll offer you an example inventory log. Next thing to think about is destruction policy. And so you have to have a way to get rid of expired medications, or if the patient comes and you prepare the injection and they don't want to actually use it, you have to have a way to destroy that properly. I think it's a DA form 41 is to use. So you don't have to, when a medication is destroyed or wasted, you have to fill out the form 41. You don't have to supply that to the DEA, but you do have to have it on record for if you come and get audited. The next step is to find an authorized supplier, set up account. Cardinal, Henry Sheen, and Bessie are all fairly popular ones that most people have at least some familiarity or connection with already, to obtain your Brixadi or Sublocade. And then you want to give your Brixadi or Sublocade, which is great. That's all I have. My final plug is just to make sure we're talking about naloxone and prescribing naloxone to our patients. This is hugely important, just to have that conversation about what an opiate overdose looks like, how to give naloxone, and then the importance of just all community members carrying naloxone and knowing how to recognize an opiate overdose. And how to administer naloxone. I can't not say this because it's my favorite thing to talk about is naloxone. But when you're counseling patients, I have a few tips and tricks to mention to them. One is to make sure that you press down really hard on that plunger. So there's a little bit of resistance, and if we just press slowly down on that plunger, then the medication will come out as a liquid, where the goal is to really create a mist. That mist is what gets absorbed and will then work to reverse the overdose for our patients. And so just making sure we're counseling them to press down really hard on that plunger. And then the other thing to note is that to make sure we tell the patient, that the person that you administered naloxone to, that that's what you did. They will wake up, they could feel confused, they don't know what's happening, they'll probably feel bad if they're a regular user and they're in opiate withdrawal. And so just saying, hey, it looked like you were struggling, we gave you some naloxone, maybe that's why you don't feel good, and just making sure that they're aware of what happened when they were out is another really important counseling point that I think gets missed.
All right, so I think we wrapped up just a little bit earlier than expected with the content of our talk, but that leaves more time for questions. So I'd encourage anyone who has a question, submit it using the Q&A chat feature, and we'll be happy to take any questions that folks have. And I think we might have one already.
So yeah, Elisa, you have one question so far, and that's, are there any medications that have been found to be helpful for people with methamphetamine use disorder?
Great. I love this question. Thank you so much for asking that. There are no FDA approved medications to treat stimulant use disorder. There are some medicines that have been studied off label that have been shown to reduce rates of methamphetamine use and methamphetamine cravings. Probably the one I use the most often, both in the hospital and the clinic, is bupropion. There's some good studies showing that bupropion can reduce cravings for methamphetamine and methamphetamine use. In the short term, it can also help, at least to a small degree, alleviate some of the symptoms of methamphetamine withdrawal, such as the extreme fatigue that people get. Um, I typically start at a low dose, 150 milligrams for at least the first few days. I like using the extended release, the XL formulation. And if someone tolerates it, I'll increase it after about 3 to 7 days to 300 milligrams. You may even consider going up to 450, which was the dose that was studied. Um, what I would say reasons not to use bupropion, someone who has a seizure disorder, an eating disorder, you may use it with extreme caution. In someone with bipolar disorder, because there's a risk for precipitating mania, um, or anyone who hasn't been able to tolerate it in the past. There's also some evidence for using mirtazapine at 15 to 30 milligrams, usually starting at 15 and then titrating up to 30 milligrams. There have been several small studies showing efficacy. I think some of the reasoning behind why mirtazapine might be helpful is around resetting the sleep cycle. It's really common that people who use methamphetamine have a disruption in sleep. And even in withdrawal, even if they appear to be sleeping and fatigued, often they're not getting good quality sleep at night. Mirtazapine is a sedating antidepressant. It's taken at bedtime and has shown some of that efficacy. Um, what I would say is that, if it's causing too much daytime sedation, that's really the biggest side effect I see with it. You take it at night, maybe you're still groggy in the morning. That tends to be one of the reasons why people discontinue it. It can also stimulate appetite. So if you have patients that are underweight, which can often go along with heavy use of methamphetamine, it can help support healthy weight gain. The other medicines that have been studied, so naltrexone, especially extended release naltrexone, has been studied in combination with bupropion. In the context of this talk, naltrexone would not be an option because we're talking about patients who are on buprenorphine. Naltrexone is an opioid antagonist. If you give naltrexone to someone who's on buprenorphine, it will put them into opioid withdrawal. In the situation where you have someone that's been off all opioids, naltrexone may be an option for them if they've been off for at least 5 to 7 days of all short-acting opioids and 14 days of long-acting opioids. And then there's some evidence for N-acetylcysteine as well as a potential option. It's a whole separate talk. Maybe we can give in the future stimulant medications for methamphetamine use disorder, but there are some new guidelines, especially for patients that have co-occurring ADHD, using methylphenidate to treat both ADHD and a stimulant use disorder. So all of that is off-label. What we really have the most evidence for is behavioral therapy. So things like contingency management. There's very good evidence for contingency management as an effective treatment for stimulant use disorder. All right.
That's great. Thank you. Do you want to just give a little, just like a 1 minute or less on what contingency management is for those who might
Yeah.
not know?
Oh, yeah, I'd be happy to. So it's a behavioral therapy. And actually, contingency management isn't just specific to stimulant use disorder. There's actually good evidence using it along with medications for opioid use disorder to treat opioid use disorder, alcohol use disorder, cannabis use disorder. Like, it can be a very helpful behavioral therapy for substance use disorders in general, or to motivate any positive behavior change, even things like healthy eating, exercising regularly. The whole idea behind contingency management is that you select some type of target behavior. This could be a negative urine drug screen. This could be eating less ice cream. This could be running 3 days a week. Whatever the target behavior is, you pick it, and then you have to have a way to measure it. And often in substance use disorder treatment, that may involve coming to an appointment, submitting a drug screen. And so you're measuring that outcome and then you reward it. And that could be a financial reward, it could be a prize. These are, there's a number of different ways that you can provide that reward. Sometimes it's spinning a wheel, picking something out of a fishbowl. There's all different ways to make contingency management fun. But the whole idea is you're promoting positive behavior change, you're rewarding positive desired behavior change through this type of therapy that's stimulating the brain to release dopamine in response to that positive behavior. You're rewiring those pathways in the brain that become dysregulated when someone is using a substance or doing a negative behavior regularly. There's a lot of myths. We're talking about myths. So many myths about contingency management as like, oh, we're paying people to not use drugs. I do not think about it that way at all. We are using a positive motivator, which can be financial, to promote behavior change, stimulate dopamine release in response to that desired behavior. And if you look around you, there's contingency management everywhere. It's really something that I think we see and we use in our day-to-day lives. We just don't call it contingency management. It could even be like being incentivized to show up for a talk by, hey, they provided sandwiches. It's promoting that behavior change. I'm going to come to that talk because there's food there.
Or maybe a gift card for your flu shot. Another example.
Sure.
We have two other questions. I think let's go to Emily for one of them. About is it common to need to give people multiple Narcan doses and in an overdose event?
Great question. So I think this is multifactorial. There is some theories out there that the standard Narcan 4 milligram dose isn't enough and you have to give multiple doses to reverse an overdose. I think that's multifactorial. One, fentanyl is potent, and so sometimes depending on the dose that the patient took, maybe you do need higher levels of naloxone to kick enough fentanyl off those receptors to stimulate the drive to breathe again. I also do think because there's more Narcan out there in the community, which is great. There's more bystander administration of Narcan, which is really great, but it could be that the Narcan's not giving properly. So like I had mentioned earlier, if you don't create that mist, that liquid is not going to be absorbed to work to reverse the opiate overdose. And so proper administration of the Narcan can also play into it. So you give a dose, you give it improperly, it doesn't work, so you give another dose. And so I think the proper administration of naloxone is a really good counseling point for everyone who carries naloxone. I think the other thing that plays into it as well is that you should ideally wait 2 minutes between each dose of Narcan that you give. When it's your loved one that's down on the floor, not responding, it's really hard to wait 2 minutes between each dose. And so oftentimes it's given every 30 minutes, every 30 seconds, every minute until the person responds, which may not totally be necessary. We just need to give that naloxone time to work. But it is really hard. I would have a hard time waiting 2 minutes, I think, in between doses as well. So I think the phenomenon where we're needing more doses to reverse overdose is really multifactorial and not just related to the fentanyl potency.
Thanks, Emily. And let's see here. And then we had another question about bupropion in patients with severe CHF related to methamphetamines.
Oh, that's a great question. So I would say the biggest caution with using buprenorphine in patients with severe congestive heart failure is that it can increase blood pressure, it can increase heart rate, and it's important to monitor for that. Bupropion has been studied post-MI in patients for depression and smoking cessation. So not specifically for methamphetamine use, but for some other indications. And it hasn't been shown to increase the risk of heart failure, the risk of arrhythmias in that patient population. So I'd say you could still consider it. I'd use it with caution, monitoring for blood pressure and heart rate changes, and certainly being on bupropion, not using methamphetamine in the setting of severe CHF is going to be lower risk than using methamphetamine. So if with working with a patient, they feel like that's going to be a helpful part of their treatment plan to reduce or stop their methamphetamine use, I would consider it. Again, bupropion is off-label. There's more evidence for behavioral therapy like contingency management. So if you're in a situation where the patients may be more on the fence, you may want to start with behavioral intervention. Emily, do you have other additional thoughts about that? Okay.
No, that was great. Yeah, it's heart rate and blood pressure. And really, if you go and look at the data, the increase that you see in blood pressure is usually quite minimal with bupropion. It's not as significant as we all maybe think it is.
Thanks to both of you. If you are listening and you have a pharmacist in your clinic, I would encourage you to see if they're interested in helping to support any of this MOUD work. So that's been really helpful working with you, Emily, from the pharmacy perspective. We put a couple of resources in the chat. One was on contingency management for folks if they want to learn more. And another is from our website, Reverse Overdose Oregon, that has some videos on how to use naloxone. I don't see many other questions in the chat. It would be really helpful if folks could just take a minute to, or 30 seconds to just type in what your biggest takeaway is from this session. So we can kind of share what is, oh, there is another question. If your naloxone is expired, is it still safe to administer as a last resort? So maybe Emily, you could answer that while folks are putting their takeaways in the chat.
Yes, absolutely. There was an interesting study that showed naloxone is still effective for 2 years after the expiration date, which really drives with what we know and the limitations that the FDA puts on how you determine expiration dates. So yes, absolutely. If it's expired and you have nothing else, please use it. The naloxone is also really safe. So if it's expired, you're not going to hurt someone by giving them expired naloxone. It just may not work or may not work as well. It's going to lose some of the potency. So instead of being, 4 milligram dose, maybe it's a 3 or 2 milligrams that actually gets given to the patient. But you certainly won't hurt them. Which is another important counseling point too that I could bring up as an aside. If someone is down and unresponsive, even if it's not from an opiate overdose, you're not going to harm them by giving naloxone. There's no disease state, there's no med interaction, there's nothing that naloxone will make worse if the patient is unresponsive from anything else besides an opiate overdose. So it really is a safe medication.
Thank you. It's really helpful. Any other takeaways that folks want to add to the chat or last questions? Okay, the resources are available. Everything we put in the chat will be available for everyone. We'll send those out with the slides. I know that our presenters are happy to answer other questions. If you're thinking about them throughout your day, you have some more follow-ups, they'll be happy to answer those. You can email them. I think we're always grateful to be able to talk about buprenorphine, and I was struck by the reminder of the change around benzodiazepines and how long ago that was and how it really has stuck with a lot of our prescribers. And so just really grateful for this opportunity to just get the real information. And we hope that those of you on this call who that was new for or kind of shifted your perspective, that you're also able to share with your colleagues and friends about the different thoughts that we have around buprenorphine over the last many years in terms of other substances, and then of course getting more comfortable with how to provide long-acting injectables. And I think I'll just end on the note of making sure that you have naloxone at all times and know how to use it. I think that's it for today. Thank you, Kayla. I was going to end without the biggest questions answered. So we'll be sending you a survey for the CME credit where our presenters are available for questions, carry naloxone, prescribe buprenorphine. Reach out if you have questions about how to do it and utilize the resources that we're sending you. We're so grateful for your time on this early morning to spend with us to talk about these topics. And thank you so much to Emily and Elisa for your just expertise and answering all the questions and sharing your time with us this morning. Thank you so much.
Thanks for having us.